Okay, thank you for invitation, and apologize for my voice due, I suppose, to the very cold atmosphere inside the airplane. Anyway, I will try to make you understand. Thank you, Professor Wright. It's been a pleasure to share this occasion with him. We started in 2005 with the RFA ablation, and in 2008 we invited Professor Wright in our hospital. We did the first case at the time, and since then we continue to use this technique with this. I assure you that we had really satisfaction. I have to talk about the idea of a variable needle, a variable deep-acting needle, and the idea comes from the necessity to optimize the treatment. This is the first study we performed in Italy in 2018. We took six centers, involved more than 300 nodules. They were pretty large nodules, 20 ml. I will talk always about volume, okay? The idea was said that the first speaker, I subscribe with decision. We have to talk about volume, otherwise we can't understand if we just talk about maximum diameters, etc. Let's use to the volume. So they were 20 ml volumes, which are a needle range volume, and in 6 centers you see that after just one treatment, just one, and the follow-up at 12 months, we had a reduction of 70%, with very few side effects, no major complication. Same data published by the Korean colleagues, by Professor Baek, and also for them the reduction was very good. Is this? Yes, 80%. Volume not so large; they were smaller, and he started to see which were the variables connected with the final response of the nodule. Very few side effects also in this group. And so we started to reason about general efficacy. First meta-analysis came out. This is one of, my opinion, more important meta-analysis. You see 1,000 and more nodules. Just after one treatment is 71% of median reduction. Remember that the technical efficacy is considered a reduction of 50%, by which you can have regrowth in less than 20% of the patient. Okay, so that's the minimum we have to reach. That is true for cold nodules, but it's true also for hot nodules. Here you see our first paper published with the other technique in very large ancient patients who were not for surgery, and anyway are not bad. Which are the factors affecting efficacy? I don't talk about the venous and arterial ablation, but just of the variables connected to the selection and to the modality of the treatment. Okay. The nodule structure is the first one. First paper published by Professor Baek and others showed that more mixed or cystic were the nodule, more they used after the treatment. Okay? And we showed the same thing in our study, where we showed that vascularization was important to have a reduction. So if you ablate the vessel, it's true what he's saying, but also the microcystic pattern is better, it reduces better than the solid one. As they confirmed in the other paper. This is valid also on laser. This is a laser paper, and you see that also for laser is true. So heating is better if the structure is not solid. Second, vascularization is so we go very fast, not so strong as I expect, you see, but anyway it is confirmed. Third aspect, nodule size. Nodule size is critical. So I would throw a stone in the lake, in the Michigan lake, saying that I don't agree about the strength on the symptomatic nodules. We have to treat the growing nodules. We have 10% of the nodule of goiter, okay? So if we wait, they are symptomatic. There are people who are symptomatic with a 10 milliliters nodule, but some who becomes after 90. And when you are at 90 millimeters, you have to go to the surgeon. So in my opinion, are the growing one. Anyway, you see that the volume is critical for a reduction because a small nodules has a reduction of 80%. First paper published by the Korean group. Large nodule has a reduction of 60. These are nodules of 50 ml, okay? Our paper showed the same thing. The small one go better, 75% after one treatment. And the second paper of the Korean group said strongly the same aspect. This is a meta-analysis that performed by Stella Bernardi and Thyroid, in which are compared the laser, radiofrequency, put all together, etc. But anyway, the basic volume is a critical one. And that values also when you perform a long follow-up. This is our paper, 5 years of follow-up. You see that the difference at 5 years remains connected to the initial volume. So the question is, but what does the volume so important, so as a factor conditioning the final result? We study about energy. We tried to see if there was a correlation between less energy in large and more energy in small. And it looked like that. Because if you see here, in the group of the small nodule, generally we deliver about 3,000 joule, while in the larger one, 1,200 per ml of volume. This data is not new. And we try to make a sort of correlation in a group of controlled nodules in which we control all the variables. The single power was not correlated. The energy calculated was not, the duration was not, was just the energy delivered per ml. And then we perform a second study together with Professor Giroux in Paris. We randomized a group of patients. We applied the same protocol, energy protocol, with different volumes. You see, not a large study, works more than 100. And we showed there is a sort of threshold the threshold of 1,500 joules per ml is the threshold in this study that can guarantee you a reduction, a nodule reduction of more than 50% in more than 80% of the patient. Okay? And that happens in small one, in medium one, and large one. So energy is a factor important. This is the reason why we started to understand if it was possible with very large nodule to have the same result using a needle which gave us the possibility to deliver more energy. Because the ablated area is dependent from the tip, from the place from which comes out the energy. And you see that laser is different in spite of radio frequency, microwave is different, etc. This paper here gives you the idea of what is possible to do. We used this needle, which is a variable active tip needle. You can change the active part during the treatment while the needle is inside the neck. And we started to see what happened. At the moment, these are preliminary data, are not published. What we realized was that 65 patients, first group, basal volume between 60 and 230 mL. Okay? Active tip open at 3 centimeters. Delivered for ml of volume 1,800. Duration about 30 minutes. If some of you has tried to treat a nodule of 2,000 or 200 or 150, so half an hour is really just what you can do or what the patient can stand, because sometimes you can't remove. In nodule large but medium large, between 30 and 60, we open 25. Between 20 and 29, we open 20. So, this is what happens. What we discovered also is that it is easier. You have to move less times because there is a very large spreading. You just have to wait. Impedance stay down. And you have to go up with the power. With a 2 centimeter opening, you work between 100 and 120 watts. Otherwise, it doesn't work, okay? This is gives you an idea of a subgroup of the nodules or what happens. These are all of them, and you see that at 1 month, there was a reduction of about 30%. At 6 months, 50. At 1 year, more than 60%. The same reduction we had in this group, the same with the volume, with an energy delivered per volume similar to the best group, not to this one who didn't shrink in the multicentric study we did. And this is the idea of a patient. Okay? This is at the base, and this is 6 months, with after a large nodule. Recent guideline, I wanted to remember you that when we started, we had to face with this idea, no? That RFA may be an effective tool, but we have to consider also laser, and use it in nodule progressive enlarging. Then came the Korean guidelines. We were decidedly more in favor of RFA, and finally Also, the European were decisively more important and gave to RFA a first-line position for the treatment. So my conclusion is RFA has shown to be effective in the treatment of growing and compressing before growing. Efficacy is persisting. In our group, we treated more than 1,000 patients. The percentage of regrowing, of necessity of second treatment, is less than 10%. So it's possible to have good results. In larger study is less than 5. Major complications are occasional. What, in my opinion, in our opinion, is critical is for final success is the volume. Don't go over 30 mL, otherwise it's more difficult to have with a single shot the final result persisting in the time. Choose nodule with microcystic structure. If you have large nodules which are solid, perhaps it's better to think to the surgeon. And better if they are vascularized. Don't worry about it. Make the ablation of venous and afferent artery, which is very important, and don't be frightened about it. The methodology of treatment is very important. And we, in our work, in our daily work, use this threshold to be sure that the treatment is conducted with at least the sufficient energy possible. In large compressive nodules, in our opinion, this new tool is very useful because the increased energy spreading in large nodule. Obviously, we have to follow up this nodule to understand which is the percentage of recurrence in this case, and thank you.